Good morning, dear learners, and once again, welcome to the MOOC on Rural Development in India. We are in week 10, and this is module 34, and here we shall discuss about government policies and programs in health in India. As you know, good health and well-being are the foundational pillars of human resource quality and are fundamental to the development strategy of any nation. The age-old adage, health is wealth, remains a critical metric for measuring national progress. Yet, for decades, achieving health for all in India has appeared to be a mirage. India currently faces a complex triple burden of diseases, comprising of an unfinished agenda of communicable diseases, a rising prevalence of non-communicable diseases such as diabetes and cardiovascular conditions, and the emergence of new infectious threats like the COVID-19. Historically, India's public health spending has remained abysmally low, hovering around 1% of its gross domestic product, which is significantly lower than the global average of 9.7%. This chronic underfunding has led to a fragmented system where nearly 70% of healthcare spending is borne by individuals as out-of-pocket expenditures, pushing approximately 63 million people into poverty annually. While the government has transitioned from being a sole provider to a facilitator, the challenge remains to provide quality, affordable healthcare to a diverse population of over 1.4 billion people. Now, please note that already in the previous module, we have already discussed the major health issues in rural India and contours. And in this module, we shall try to examine the evolution of India's health policy framework from colonial measures to the ambitious targets of the modern era. Now, looking at the policy frameworks and measures since the British period, the origins of India's formal health public movement can be traced to the colonial administrators' need to manage epidemics that threatened military and administrative stability. Initial measures were largely reactive, such as the Quarantine Act of 1825 and the Epidemic Disease Act of 1897, the latter of which remains a functional legal tool today. Early colonial healthcare was markedly urban-based and allied-centric, focusing primarily on army personnel and colonial administrators while neglecting the vast rural masses. The Government of India Act 1935 established the structural precedent of decentralization by transferring the responsibility for public health, sanitation, and medical education to provincial governments, a division of power that persists in the modern constitution. In 1943, the British government appointed the Health Survey and Development Committee, chaired by Sir Joseph Vaux, which submitted its landmark report in 1946. The Vaux Committee report, as it is known, is considered the most comprehensive health plan ever prepared for India, drawing a blueprint for a national health services that would provide universal state-funded coverage regardless of an individual's ability to pay. It recommended a three-tier system for primary, secondary, and tertiary care, laying the foundation for India's hospital-based public health system. Post-independence, India adopted the five-year plan model to steer development. And during the first three plans, spanning the period of 1951 to 1966, the focus remained on managing ravaging epidemics through technocentric national campaigns for malaria, smallpox, and tuberculosis. The 1950s saw the launch of National Malaria Control Program, which dramatically reduced cases from 75 million at independence to 2 million by the late 1960s. And despite such successes, the systematic expansion of primary healthcare infrastructure was often outpaced by population growth, as noted by the Modular Committee in 1961. The 1970s marked a shift toward addressing rural neglect through the Minimum Needs Program, MNP as you call it, in the fifth five-year plan, which aimed to provide basic health facilities and safe drinking water to all villages in the country. And globally, the 1978 Almata Declaration, to which India was a signatory, redefined health as a human right and primary health care as the vehicle for achieving health for all by 2000 AD. This international commitment directly led to the formulation of India's first national health policy in 1983. The National Health Policy in 1983 aimed to provide a well-dispersed network of primary healthcare services through community participation and the training of health volunteers. However, the 1990s brought economic liberalization, which inadvertently encouraged the growth of a dominant, largely unregulated private sector, while public investment remained stagnant. This was followed by the NSP 2002, National Health Policy 2002, which admitted that the ambitious goals of 1983 remained unfulfilled due to administrative and resource constraints. Now, National Health Policy 2002 sought to increase public health spending to 2% of GDP and encouraged the decentralization of health services to the district level. These historical frameworks collectively shaped the modern health landscapes, leading to significant improvements in life expectancy, which rose from 27 years in 1946 to over 70 years recently, even as systemic inequities between rural and urban sectors persisted. Now let us make a brief assessment of the different policies India adopted. Assessing India's health policies require a look beyond macro indicators like life expectancy to the micro realities of access and quality. The National Health Policy in 1983 was a visionary document that embraced the primary healthcare model, yet it suffered from a critical lack of financial roadmap. While it succeeded in expanding the physical network of sub-centers, primary health centers, it could not prevent disproportionate concentration of curative facilities in urban areas. Furthermore, its call for community-led health volunteers was never fully institutionalized, leaving a gap of grassroots service delivery. The National Health Policy 2002 attempted to correct these imbalances by explicitly judging its own success based on equity norm, and it advocated for a higher allocation of funds, 55%, to the primary health sector. However, a major critique of National Health Policy 2002 is that it departed from the universal health care commitment of NSP 1983, remaining silent on the concept of comprehensive coverage while legitimizing the privatization of the healthcare delivery system. While it welcomed private sector participation in all tiers of health, it failed to establish the necessary regulatory mechanisms to protect the poor from exploitation. The 5-year plans provided the administrative framework for these policies, but often adopted a one-size-fits-all approach that ignored regional diversities. For example, early plans prioritized economic and industrial growth, leaving health as a residual social service. It was only in the 8th 5-year plan of 1990 to 1997 that public health became a specific focus area. Yet, even then, implementation was marred by bureaucratic inefficiencies and a lack of coordination between various agencies. And various expert committees provided critical insights that shaped these policies. The Srivastava Committee of 1975 led to the launch of rural health services by recommending the creation of village-based health worker, while the Krishnan Committee of 1982 focused on urban primary health posts. However, many recommendations, such as the creation of an All India Health Service by the Mudaliar Committee, as you already had mentioned, were never implemented. The overarching assessment of these policies reveals a consistent trend: ambitious goals set without matching financial commitments. Public health expenditure remained trapped at around 1% of GDP for decades, far below 5% recommendation by the World Health Organization. And this underinvestment forced the population to depend on the private sector, resulting in higher out-of-pocket expenditure and making health policy a contributor to financial insecurity for the marginalized. And the failure to address social determinants like sanitation and nutrition is an integrated manner meant that health gains were often superficial. In essence, while policies evolved in sophistication, they consistently struggled with the inverse care law, where those with the greatest medical needs received the least attention. Now let us review India's most successful plans like the NRHM 2005 and the National Health Mission. The National Rural Health Mission (NRHM), launched in April 2005, represented a paradigm shift in India's health strategy by moving into mission mode to provide accessible, affordable, and quality healthcare to rural populations. It was a homegrown model designed to strengthen the public health system through community ownership and decentralized planning. And in 2013, NRHM was renamed the National Health Mission (NHM), subsuming both the Rural Subcommission and the newly created National Urban Health Mission to address the needs of the urban poor as well. And one of the most significant successes of NRHM was the introduction of accredited social health activists, ASA as we call it. And over 1 million trained female volunteers were deployed to act as a crucial link between the community and the public health system, facilitating institutional deliveries and immunization. And this initiative, along with the Janani Suraksha Yojana (JSY), led to a substantial increase in institutional deliveries. And institutional delivery was only 31.1% in 2005-6, and this was more than doubled to 75.1% in a decade's time by 2015-16, which has further increased to 91% in 2023, and a significant decline at the same time in maternal mortality ratio (MMR) and infant mortality ratio we see. And National Health Mission also succeeded in fastly expanding rural health infrastructure. Between 2005 and 2013, over 146,000 sub-centers and 23,000 PSCs were operationalized, many upgraded to function throughout 24/7. The program also integrated the Indian system of medicine, basically IOS, into mainstream healthcare and promoted community involvement through Rogi Kalyan Committees, hospital management societies. Epidemiologically, the mission made great strides in containing malaria, with mortality reducing by 70% between 2005 and 2012, and successfully maintaining high tuberculosis cure rates. Now, when we see at the failures or challenges the NHM or NRHM faced, we see that despite these achievements, NHM faced critical implementation failures. A primary failure was the persistent shortage of human resources. Even as buildings were constructed, a 66% shortage of health workers and nearly 80% shortfall of specialists in community health centers remained in 2017. This led to a system where infrastructure existed but was not functional to its full potential. And corruption and financial mismanagement also plagued the mission in several states. Performance audits in states like Goa revealed that procurement policies were often missing, leading to shortages of essential drugs despite being mandated as free. Furthermore, the one-size-fits-all approach failed to achieve parity between states. While Kerala and Tamil Nadu utilized NHM funds effectively to achieve near-developed county health indicators, northern states like Bihar, Uttar Pradesh continue to struggle with inadequate infrastructure and weak governance. Additionally, while NHM aimed to raise public health spending to 2 to 3% of GDP, overall expenditure still remains stagnant at around 1%. This underfunding resulted in a continued reliance on out-of-pocket payments, which still accounts for over 50% of total health expenditure in rural areas. And the mission also struggled to address rising non-communicable diseases as it remained largely focused on the low-hanging fruit of maternal and child health. Now let us look at the National Health Policy 2017. The National Health Policy of 2017 was formulated 15 years after its predecessors to address a vastly changed healthcare landscape, including the rising economic growth and the double-digit expansion of the private healthcare industry. Its primary aim is to inform and strengthen the government's role in shaping health systems through increased investment and cross-sectional action. NSP 2017 is built on 10 key principles, including universality, equity, and affordability. It proposes 7 major policy shifts, most notably moving from selective primary care to assured comprehensive care through the creation of 150,000 health and wellness centers. These centers are designed to manage non-communicable diseases and provide palliative and geriatric care, making a departure from the earlier focus on basic maternal health. Thus, the policy also introduces the concept of strategic purchasing, where the government acts as a single payer to buy secondary and tertiary care services from both public and private providers to fill critical gaps. The policy sets ambitious time-bound targets, such as increasing life expectancy from 67.5 to 70 years by 2025 and reducing the total fertility rate to 2.1. And it also commits to raising public health expenditure to 2.5% of GDP by 2025 and ensuring that state governments allocate more than 8% of their budgets to health by 2020. A major appraisal of NSP 2017 reveals that it continues to suffer from the same incrementalism as previous policies. While it articulates the need for 2.5% GDP spending, it fails to provide a concrete roadmap to achieve this, as public spending remained broadly unchanged at 1% of GDP 5 years after its rollout. And many targets of 2020, such as state budget allocation, were largely missed, with most states spending only around 5% on health. Furthermore, while the policy focuses on tertiary care through the Ayushman Bharat Prime Minister Jan Arogya Yojana insurance scheme, critics argue that this approach may neglect the primary healthcare foundation if funding is merely diverted from existing programs. The PMJAY scheme itself has limitations. It primarily covers hospitalization, while 47% of individual health expenditure is actually spent on pharmacies for outpatient care, which remains uncovered. The policy's emphasis on digital health and Aadhaar-based authentication, while aimed at transparency, faces significant hurdles in rural areas where only 25% of the population has reliable internet access. So, in summary, while NSP 2017 is a comprehensive document that aligns with the Sustainable Development Goals, its ultimate success depends on political stewardship and the strategic deployment of resources rather than just grand announcements. So, here in this module, we have discussed that the evolution of India's health policies has been a journey from colonial era epidemic control to a modern quest for universal health coverage. While landmark initiatives like the National Rural Health Mission and the National Health Mission and NSP 2017 have led to significant improvements in mortality rates and life expectancy, the core challenges of low public investment persist. Health has historically remained a low political priority, leading to a system that is curative, heavy, and urban biased, leaving the poor vulnerable to a catastrophic out-of-pocket expenses. And in Table 1, we present a summarized view of the major health programs and policies in India. Here we see during the colonial era, medical services, IMS and PMS. This was launched in 1896 and aim was to provide medical care for the military administrator and industrial hubs to control epidemics. Indian medical services, civil surgeons at district level were the main service model. And we also see the target beneficiaries, implementation challenges, and also impact or outcome metrics. Similarly, next we see the Health Survey and Development Committee, 4 Committee of 1943, which was actually implemented in 1946. Report was submitted in 1946. And here also we see the primary objective was to prepare a detailed plan for a national health service, providing universal coverage free of charge. And as we already indicated, this was the major health policy formulation in India. Then we see Health Survey and Planning Committee, Modular Committee, that was constituted in 1959. And its primary objective was to evaluate progress of first to 5-year plans and recommend improvements for health services. Similarly, we see the Pradhan Mantri Swasthya Suraksha Yojana, which was introduced in 2003, and its primary objective was to correct regional imbalances in tertiary care and augment facilities for quality medical education. Then we can see here the National Rural Health Mission, NRHM, which was introduced in 2005. And its basic aim, as we already discussed, was to provide accessible, affordable, and quality healthcare to the rural population, reduce IMR and MMR. And it followed the state-tier infrastructure of SCs, PSCs, and CSCs. ASA was an innovation of this framework. ASA workers, Rogi Kalyan Committees, okay, these were innovations of this thing. And the IPHS standards were also incorporated in the NRHM 2005. And here the target beneficiaries basically were rural population, especially the 18 high focus states, the vulnerable sections, pregnant women, and neonatals. The implementation challenges NRHM phase was shortage of specialists. 81% of 17,500 shortfalls were found in CSCs. And also we saw some of the corruption in northern states, poor accountability, inefficient fund utilization. Okay. Major outcomes, as we see, were IMR reduced from 58 in 2005 to 30 in 2023, and MMR also reduced to 103 in 2023. And 9.3 lakh ASA Kormis ASA activists were deployed. And institutional deliveries also significantly increased to 91%. Then, as you see also here, ASA was introduced in 2005 as a part of the NRHM, and we can see its primary objective were to increase health awareness, facilitate institutional deliveries, and provide primary care for minor illness at the village level. And as you can see, ASA was a good, successful initiative. Then in 2005, we also see the Village Health Sanitation and Nutritional Committee, VHSNC. Okay, primary objective was to promote equity and support people-centered responsive health systems at the village level. Then standing committees of the Gram Panchayat were formed, including ASA, ANM, Anganwadi workers, and community members. And the target beneficiaries were basically the village residents. It was in rural areas. Then we can see the Rashtriya Swasthya Bima Yojana, RSBY. And it was initially introduced in 2008, and major aim was to reduce out-of-pocket expenditure for BPL families and unorganized sector workers through health insurance. And basic model was introduced smart card-based cashless service. Sum insured cap was 30,000 per family per annum. And the target beneficiaries of this RSBY was the BPL families and workers in the unorganized sector. However, the challenges faced by this policy was low awareness, almost 35% were unaware, then failure to significantly reduce out-of-pocket expenditure, and hospital hesitation, then fraud by insurance providers. These were some of the reported irregularities were found in the policy. Then Janani Sishu Swasthya Karyakram, JSSK. It was launched in the year 2011, and primary objective was to provide free, non-expense delivery for pregnant women and treatment for sick newborns in public institutions. Main components were like free diagnostics, drugs, diet and transport home to facility, and referral. Then all pregnant women delivering in public institutional and sick newborns up to 30 days were its target beneficiaries. But while implementation challenges were faced in this policy was regarding human resource shortages and funding substitution gaps at the facility level. And the National Health Mission was introduced in 2013 as its primary objective was to attain universal access to equitable, affordable, and quality healthcare accountable to people's needs, subsumes NRHM and National Urban Health Mission. And these were integrated into one National Health Mission in 2013. And it basically worked on the three-tier health system model, SCs, PHCs, and CHCs. And flexible pools were there. Then health system strengthening, urban primary health centers were established, were operationalized. So it targeted both rural and urban areas, focusing on the poor, disadvantaged, and marginalized particularly the SC, ST, OBC communities. But the major implementation challenge it faced was one-size-fits-all policy, fund release below allocation, weak enforcement of Clinical Establishment Act, and persistent human resource shortages. And then was introduced the National Urban Health Mission, NUHM, in 2013. Then also Swachh Bharat Mission in 2014. Its objective was to eliminate open defecation through construction of toilets and community awareness generation. A key infrastructure or service model was the campaign mode delivery, high level of political support, real-time monitoring via dashboards, community mobilization, and basic target were the rural Indian households. The implementation challenges it faced was the systemic incentives to over-report results, sustainability of toilets use, inequalities in original government baselines. Then regarding the National Health Policy of 2017, its primary objective was to inform and strengthen the government's role in shaping health systems through increased investment and cross-sectoral action. And the NSP 2017 is built on 10 key principles, including universality, equity, and affordability. And it targets the entire population of India. But the operational key challenge was out-of-pocket expenditure on medicines are not covered. Okay, basically, rural population often finds catastrophic problem in arranging this medicinal cost, which is often nearly 50%. So this policy did not cover these expenditures. And the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, PMJY, it was introduced in the year 2018. Basic objective was to provide financial protection for secondary and tertiary care hospitalization, reduce out-of-pocket expenditure, and catastrophic health expenditure. Basically, it's an insurance model. Rupees 5 lakh coverage is given per family per year, and cashless, paperless service is provided at the empaneled public and private hospitals. Target population is 107 million poor and vulnerable families, approximately 500 million people, identified by SCCC 2011 data. And major implementation challenges are lack of awareness, outdated SCCC data, low budget utilization, only 42% in 2020-21, and fraudulent claims, and substitution of funds from existing programs. Similarly, we see the Ayushman Bharat Health and Wellness Centers. It was introduced in 2018 to deliver comprehensive primary health care, including preventive, promotive, and rehabilitative services. And there is this Ayushman Bharat Digital Mission, introduced in 2021, to create a holistic digital health ecosystem and standardize personal health records. So, to truly transform healthcare, India must move beyond incremental changes. It is imperative that both the central and state governments commit to raising public health spending to at least 3% of GDP in the short term, with an ultimate goal of 5% to bridge the massive gaps in human resources and rural infrastructure. The future of India's health system lies in a holistic approach that integrates digital innovation and public-private partnerships with a renewed, well-funded focus on preventive primary care. And only through sustained financial commitment and rigorous governance can India ensure that quality healthcare is not a privilege for the few, but a fundamental right for all. So with this, thank you. We come to the end of this module. And in the next module, we shall start the 11th week of this course on the issue of vulnerable groups and rural development. Thank you.